Hello, everybody, and welcome to the ASAP webinar series on the topic today is optimized human resources for health staffing. My name is Catherine Brokenshire-Scott, and I'm the project director for ASAP. And today our presenters on the topic optimized human resources for health staffing include Geraldine Hoover and Diana Frimas from USAID. We have Sam Peary and Joab van Oosterhout from Partners in Hope, and Goodluck Mwakitosha from Benjamin Mkapa Foundation. I hope I pronounced everybody's names correctly. My sincere apologies if I did not. So I have a brief introduction for you to welcome you to this webinar. Please use the Q&A tab to ask any questions. It's at the bottom of your screen, and we will be pausing during the presentation for you to get your questions answered. We will also be sending all the questions to the presenters, and they will have an opportunity to provide responses in writing. We will be launching a poll 30 minutes before the end of the webinar, so please take the time to answer these questions. They help us shape future webinars. As always, all of our webinar presentations, recordings, questions, and answers are available on our website, www.intrahealth.org/ASAP resources. And in addition, we will be emailing the presentation after this webinar to all the participants online right now. I want to share a little bit about upcoming webinars. On April 15th, we have a very important webinar on USG legal and policy requirements for HIV/AIDS programs. As you know, we have a new administration in the US, and when that happens, we have changes in our policies. And so this particular session will go over all of the policies that are applicable to Pepfar programming through USAID. On April 21st, we have a session that's very popular on overhead, NICRA, and 10% de minimis. So this topic will cover how can local partners get some indirect costs to cover activities and costs that are not included and directly billed to USAID. On April 29th, we have a session on HIV testing and behavior change. And on May 19th, we have a session on procurement, logistics, property management, and compliance issues. We also have all of these in French for our Francophone participants, and we have a separate listserv for them to join. So thank you. I am going to turn it over to my USAID colleagues. And Jeff, you could start sharing now.
Welcome, everyone. We're really thrilled to be with you all today to talk about today's topic, which is optimized human resources for health staffing. My name is Geraldine Hoover, and I'm a data analyst with the Health Workforce Branch at USAID. And we have also Diana Frimas, who's the branch chief for Health Workforce, on the line today, as well as some exciting presentations for you all. Next slide. So the agenda for today's call is that after Catherine's introduction, Diana Frimas is going to do some welcome and introduction to today's call and share an overview of USAID and Pepfar Hrh technical priorities. Then I'll go into more detail about how to collect and use human resources for health data and considerations for optimizing Hrh. And then we have two great partner presentations for you. One from Partners in Hope in Malawi that will be shared by Professor Sam Peary, and one from the Benjamin Mkapa Foundation in Tanzania, which will be shared by Dr. Goodluck Mwakitosha. And we'll have some time for questions throughout, as well as at the end. So please put your questions into the Q&A box in the Zoom platform, and we look forward to interacting with you. So I will now pass it to Diana Frimas for the introduction section. Thank you.
Great, thanks so much, Geraldine. We can go to the next slide. Next slide, please. Great. So I wanted to start today with a bit of a historical overview of Pepfar's investment in health workforce. For those of you who have recently joined the community or who have been along for over the past decade, just to kind of set some historical context. So in 2014, Pepfar achieved a congressional mandate that was given to Pepfar to train 140,000 new healthcare workers. And so at that time, the focus was very much to help achieve that mandate and to produce and develop a lot of investments in pre-service education to develop new healthcare workers. And then with the Pepfar 3.0 agenda, Pepfar revitalized its Hrh strategy with really a focus on more targeted focus on addressing facility and community level Hrh gaps to service delivery that corresponded to this overall pivot at the time to really focus more at the site level for the point of service delivery with clients and beneficiaries. And in 2018, this corresponded with development of really intensified strategies for how to advance epidemic control. And at that time, we saw many countries start to increase more investment that had already been historically in surge staffing, so additive or surge health workforce staffing to really help support advanced scale up and achievement of 90-90-90 or 95-95-95 targets. And then I think thinking through where we've been for the past year, of course, with the onset of COVID, it has really led to rapid reconfiguration of Pepfar supported staff across countries to be able to support and maintain HIV service delivery during COVID. And we've also seen leverage of Pepfar supported staff to also support COVID response in many countries. Next slide. So with this kind of timeline and historical context, health worker staffing has really been a significant investment for Pepfar. And in FY20, through what was reported in the Hrh target, and Geraldine will talk a little bit about this later on, Hrh, we know that USAID supported over 90,000 health workers globally. This is about 40% of all Pepfar supported staff that were reported in Hrh. And this is really investment to help overcome those workforce gaps and to continue to enable achievement of epidemic control. So globally, just to kind of give an overview, 58% of these workers reported fall into kind of a lay ancillary categorization, and 16% of those are clinical. And then there's some other categories of staff that were reported that Geraldine also can give more of an overview later. And again, this Pepfar supported staff has really enabled rapid adaptation of HIV services during COVID. And we know that also they've been leveraged to support the COVID response. So for example, in South Africa, Pepfar was able to quickly mobilize community health workers to support COVID, and a significant proportion of those came from USAID. Next slide. So I know today's topic is not on COVID, but I think it's really important to talk and recognize about the impact that COVID-19 has had on the health workforce and the rapid adaptations that have been made, because this also really ties nicely into the theme of health workforce optimization moving forward. So we know across the past year, countries have reported service delivery delays. We know that there has been fear amongst health workers or cross-country health systems, and where there has been, especially earlier in the epidemic, inadequate PPE. We know that COVID-19 has really impacted health workers, with a lot of health workers getting COVID-19. We've also seen globally health workers being victims of violence through the pandemic. We also have seen that majority of countries have really had to reconfigure staffing to be able to support not only HIV service delivery, but essential service delivery beyond HIV across countries. And I think that Pepfar, because of the investment that has been made in health workforce staffing, we've also been able to enable a lot of these adaptations in a much more rapid way. So we've seen things like, of course, decanting facilities with leverage of community workers to support HIV, use of mobile health teams, expanded use of telehealth, providing more virtual service, but also using virtual platforms to expand training provision or supervision provision. And I think this also speaks to, moving forward, the need for really continued monitoring of staffing and shifts to understand the impact of HRH on COVID, but also to understand what shifts are required to be able to maintain HIV services. And then think about how some of those adaptations can be maintained in the long term, where they have proven useful and also yielded efficiencies. And those all have health workforce implications. And then lastly, there's been a macroeconomic impact of COVID-19, which has affected the resource availability of HRH wages and risk allowances and hiring in some countries. And I think moving forward for Pepfar this also resonates to the need to increase focus on more optimized use of health workforce staffing, including community workers, in addition to clinical workers, how those workers work together as a team in providing services to yield efficiencies and also to ease resource gaps. Next slide. So a key priority that you'll hear more about today for USAID has been to advance health workforce data availability and also to use this data to inform optimized investments. So this is a snapshot of a slide from a recent activity that we did internally, attached to expenditure reporting in 9 OUs to collect standardized staffing data with expenditure reporting. And it identified that the average staffing expenditures for USAID programs in these countries accounted for 44% of the total reported expenditures. And it found that in those 9 OUs, 58% of those staff supported fell into an ancillary kind of category of staff. So this means like non-clinical staff who are supporting service delivery to clients. But it also found that certain categories of staff are cost drivers. So for example, only 14% of staff reported are supporting non-service delivery activities, but that these account for 42% of total expenditures going towards staffing. So it also brought up this need for better understanding of staff who are providing service delivery, and then also who is providing non-service delivery type of functions for Pepfar programs. This exercise really provided greater insights into staffing investments being made by USAID partners, and it highlighted the importance to ensure that there are optimized staffing patterns for Pepfar investments and to make sure that there are alignments to support achievement of program goals and targets moving forward. Next slide. Great. So we've talked a little bit about how data is really key to understanding and to drive HRH optimization. And so this is kind of an overview of what we need to know. So Geraldine will talk a little bit more about how we collect data and how we can look at data, but these are kind of the top things that we really want to know when we understand HRH data. So first and foremost, really, what is that staffing composition across the entirety of the Pepfar program and OUs? So this could be looked at the category of staffing, so those who are providing health workers who are clinical workers, ancillary workers, also, as I mentioned, the staff who are providing non-service delivery type of work. And then how is this staff distributed across with the PSMUs within an OU? Again, to really understanding the roles of staff. So not just the numbers, but the roles. So what are the roles of staff who are providing service delivery, and then also those roles of staff who are providing non-service delivery? How is staffing distribution across geographies or aligned to datum hierarchy for Pepfar, also aligned to where there are program targets and target achievements? So do we have staff that's well distributed to where program targets are more saturated, for example? And how then is that staffing really aligned to how targets are being achieved? So we'll give some examples of this today and how we're looking at that. And then lastly, I think because COVID-19, we're still operating in this COVID-19 environment, it's really important to still understand the impact that COVID-19 is having on health workforce staffing, but also to be able to speak to the changes that are being made to adapt to operating in that COVID-19 environment. So with that, I am now going to hand over the presentation to Geraldine, who's going to give an overview of current Pepfar health workforce data collection efforts, and then some of those examples for how we can utilize data to really inform optimized HRH.
Slide.
Geraldine,
So yes, can you hear me all?
we
Hello?
can hear you now, yeah.
Perfect, great. So I'm going to talk first about collecting and using human resources for health data and focus some time on discussing the main types of HRH data through Pepfar, and then discuss considerations for optimizing human resources for health using available data. Next slide. So this is an overview of Pepfar's HRH reporting requirements. And as Diana mentioned, the main source historically of human resources for health data, or the number of health workers that are being supported by Pepfar, has been the Hrh indicator, which is called Hrh. And that indicator captures the number of health workers who are receiving, who are working on HIV-related activities and receiving some type of support from Pepfar, as well as total spend on those workers. So historically, this is the main source of data that's been collected on HRH, but some limitations of this indicator are that it's only captured staff who are providing services to HIV clients, and it doesn't capture technical assistants or program management staff. And it also lumps many different distinct cadres into broad categories, which limits analysis to understand the link to performance. So for example, there's clinical, social service, and lay, but it doesn't tell you anything beyond that, like what the composition of the people in each of those different categories are. And so it's been a limiting factor to understand the link between certain types of staff and performance, because only those general categories have been available from Hrh. There's also staffing information that's available through expenditure reporting, because the expenditures for various staffing cost categories like clinical and ancillary health workers, as well as other staff and program management staff, all get reported into ER. But some limitations of the staffing information in ER is that all that tells us is the total amount of spend by prime partners on these different staffing cost categories. And it doesn't capture the number of staff that are being supported, just a total amount of expenditure. And it also doesn't capture the staffing expenditures specifically that are under subrecipients, because those costs for subrecipient partners are kind of one larger line item in ER. And so you're not able to look at how much, oh, sorry. I'm seeing that there's some background, apologies. Apologies for any background noise, I'll try to speak up. But yeah, there's been limitations with expenditure reporting because it doesn't disaggregate staffing expenditures under subrecipients. So in response to some of the limitations of the Hrh data for HRH and expenditure reporting information, a lot of countries have been asked by OGAC in many cases to provide more information about the type of Pepfar staff that they're supporting. This has led a lot of countries to do HRH inventories, which have captured the entirety of Pepfar's IP staffing footprint by individual cadre and role types and their associated remuneration. In some countries where these inventories have done, they've also included Ministry of Health or Global Fund staff that are working alongside Pepfar supported staff. Some key limitations, though, thus far of HRH inventories is that they have not yet been standardized across countries. However, and I'll talk about this a little bit more later, HRH inventories in Q4 of this year are being standardized and will replace Hrh as the reporting requirement that is standard for Pepfar for HRH. HRH inventories will be the new reporting requirement, and Hrh has been phased out in the Hrh 2.5 update. So next slide. So then with all this information about the types of data that are available, what are some key uses for Hrh data? Diana touched on this a little bit, but Hrh data is really useful for examining the staffing composition that you support through your program and the geographic distribution of those staff, looking at the alignment of staff with targets and performance, understanding the roles of staff that are providing service delivery, as well as those who might be doing non-service delivery or technical assistance activities and maybe not directly interacting with clients. It helps understand which types of staff drive staffing expenditure to inform where you can make adjustments to staffing. And Hrh data can be used as inputs to help estimate the total staffing needed to achieve service delivery targets for Pepfar programs. So in the next few slides, I'll talk through I'll share some examples of different ways that we are looking at human resources for health data as the health workforce branch, and look forward to discussing more with you through the Q&A afterwards. Next slide. So here's an example of how to look at the distribution of Hrh staff across an OU. So in this chart, the vertical bars represent the staffing that's being supported across different PSNUs. And the numbers at the bottom, which I see are a little bit hard to see, but the numbers represent different PSNUs in an operating unit. And the vertical bars represent the total number of full-time equivalents, or FTE, of staff that are being supported across those different geographies. The composition of the bars can show the types of staff. So in this example, it's looking at the type of staff by expenditure reporting category, whether they're ancillary healthcare workers, clinical healthcare workers, or other staff. But you could also look at this by employment title and see in more detail the types of staff that are being supported by your program across the different areas where you work. So doing it in bars like this is one way to look at it. You could also put it in a map form to show the density of staff that you support across different geographies within the areas that you work. Next slide. This slide is an example of how to use data on staffing to look at the alignment of staff compared to MER targets and performance by PSNU. So for example, on the left, what the first graph is showing is the percent of total HTS test pause targets. That's the red dot, is the percent of total targets by PSNU. And then the small blue person icon is showing the percent of the total testing service delivery staff that's being supported. So the left side is showing the alignment of testing service delivery staff to targets. And on the right side, it's showing testing service delivery staff compared to target achievement across PSNUs. This is helpful because we can look at staffing and how it's aligned to targets versus achievement. Because for example, on the left, targets can help you, looking at it by targets can help you to assess the total staffing that's needed to support the workload. So the targets that you have for a certain program area. And then for achievement on the right, you can look at staffing alignment compared to the total workload that was achieved by those staff in a fiscal year. So generally, we would expect to see some alignment between the proportion of staff that are supporting a program area and the targets for that program area. And in areas where that might be misaligned, that could identify the need to look in more detail at what might be going on in a given PSNU and what types of service delivery contextual factors might be impacting staffing and achievement in a PSNU. Next slide. So another way to use staffing data is, I mentioned, to help inform planning for total staff that are needed to support the achievement of Pepfar targets. One way that we're doing this is with a new resource called the Hrh Needs and Optimization Planning Solution. This is a new data-driven approach to support countries to help them look at service delivery staffing needs to meet targets and optimize staffing allocation to maximize Pepfar's investments for epidemic control. This new planning resource estimates service delivery staffing needs as a function of program targets for PrEP, for testing, and for treatment. It analyzes staffing gaps, and costs, and presents options for how to hire additional staff or redistribute existing staff towards more optimal health workforce allocation and investment. The new resource is a standardized approach for using Hrh data to inform staffing requirements across OUs, built on an analysis that has been done in a number of Pepfar countries by the Touch Foundation. Next slide. So these are a couple examples of the types of dashboards that are produced by this new planning resource. And I apologize, it looks like some of the slide is a little bit cut off at the bottom, but in the slides that we'll send out afterwards, you should be able to view everything here. But this dashboard example shows the current Pepfar funded service delivery staff for, this is just with sample data. So it's showing a sample country, the service delivery staff that are supporting 3 different program areas for Pepfar. So prep, testing, and treatment. So on the left, it shows the total number of FTEs of current staffing and the total current cost of those staff. So looking at current staff and the cost by cadre can show where there might be certain types of staff that are driving more of the cost for staffing than others. So for example, in that chart on the left, you can see that the total number of FTEs of medical staff, titled clinical medical, is just under 400 full-time equivalents of staff. Compare that to lay counselors, the blue bar, which had almost 980 FTEs of staff. But you can see that the total cost of supporting those individuals was quite different between the medical staff and the lay counselor staff. And in this case, that's because the medical staff have higher compensation costs than some of the lay counselor staff in the sample data set. So the total cost is lower for the lay counselors than it is for clinical medical, even though there's more total FTEs of lay counselors. But this is just an example to show how, if you look at the types of staff you support and the compensation of those staff and your total expenditure on different types of staffing, it can help you identify which types of staff are driving your costs for staffing and understand where you might be able to use that information to make adjustments or to realign staffing if you need to. Next slide. This dashboard is an example of, oh, sorry, can we go back one? Thank you. This is an example of looking at staffing needs and the gaps in this new analysis that we have. So this shows the estimated service delivery staffing that is needed and the gap between what's needed and our current staffing for this sample data set for the 3 different program areas. So the analysis shows the estimated service delivery staffing that's needed to meet targets compared to our current staffing. On the left, you can see an estimate in total of the current staffing total number and composition that's being supported compared to the total estimated need for staff to meet service delivery targets. And then on the right, you can look at that by program area for the 3 program areas that are included in the analysis. I think one thing that's interesting to note is that there might be areas where you need more total staff, but it might not be across the board that all categories of staff need to be increased. So for example, in the current staffing bar on the left, you can see there's quite a high proportion of the total that is that blue, which is lay counselors. And in the total estimated need, it's actually smaller. So it's suggesting that fewer of those types of staff are needed in the sample data here, but more of other types of staff like medical staff and case managers and laboratory staff and data clerk staff are needed. So just to kind of think through the fact that sometimes when you look at staffing needs, it might not just be a total increase in numbers, it might also be a change in the composition of staff that are being supported. Next slide. Next slide. Perfect, thank you. And this last dashboard example from the HRH needs and optimization shows profiles of current Pepfar funded service delivery staff and how those staff could be redistributed towards more optimal allocation. So this analysis suggests ways to redistribute the existing staff that are supported in an OU to better support target achievement and it displays those recommendations by program area, which is the chart on the left, and by PSNU, which is the chart on the right. And on the right, you can see there's a heat map showing suggested net changes if staff were to be redistributed to better meet the service delivery needs across PSNUs and across program areas. Next slide. Great. So now I'll talk through some considerations for using human resources for health data to help optimize your staffing investments. Next slide. So a key USAID priority for optimizing human resources for health staffing is to advance a data-driven HRH response that has greater accountability and impact on client-centered care. The ways that this is achieved are through routine and robust tracking of staffing, data-driven approaches to determine the optimal staff needed and how to allocate those staff, well-defined approaches to monitor service delivery staff performance and to address productivity or performance barriers, routinely using your data to assess the impact of your staffing investments, and especially in the last year, given everything that's happened with the COVID-19 pandemic and how that's impacted health workers, it's important to monitor the impact that COVID-19 has been having on the staff that you support. So routinely tracking staffing changes that are being made to support HIV during COVID and staff that might be supporting COVID service delivery specifically, as well as tracking concerns related to occupational health and safety of health worker staff, like issues related to COVID cases among health workers, shortages or needs for personal protective equipment, et cetera. Next slide. So the future of HRH data, as we look into this later this year and beyond, and I mentioned this as a teaser at the beginning, but HRH inventories will be an annual Pepfar reporting requirement starting in Q4 of this year. So while the final data elements of what that inventory requirement will look like are still being determined by OGAC, we recommend that partners track the following information internally right now to be prepared for this new reporting requirement later this year. So some recommended staffing categories would be looking at your staff aligned to how you report expenditures for staff in ER. So that would be separated out by clinical healthcare workers, ancillary healthcare workers, other staff, and program management staff that are being supported, which are under the other staff category. Some key data elements to make sure that you're tracking for your supported staff are the staff cadre and reflecting the role that the staff supports for your project, where across facilities your staff might be working if they're associated with one site. If they're not, which PSNU or which SNU are they working within? What's the LOE of the staff that you're supporting? Are they full-time? Are they part-time? How do they work throughout the entire year, or do they only work seasonally? What the primary program area is that your staff are supporting, and that's based on the program areas and expenditure reporting. So things like, are they supporting testing or prevention activities or care and treatment, socioeconomic services, or above site programming? And then what type of employer is supporting your staff? So are you a prime or a subprime partner? Are you a prime that has other partners that you're working with that are also supporting staff? What the annual remuneration amount is for the health workers that you're supporting, and what the type of compensation is for those staff. Are they salaried staff, or are they contractual staff that might be only receiving a stipend? Or do you have staff that are receiving non-monetary support, for example? And then for program management staff, making sure that you're tracking the types of cadres that you support who are doing program management work, the geographies that those staff are working within, what the LOE is of those staff, and other details like what I discussed for the other types of healthcare workers. Next slide. So this slide is a summary of the COP21 guidance on optimizing human resources for health staffing. The overall guidance is to review the available HRH staffing data and identify how to further optimize staffing investments. To do this by using the most recent available HRH data that you have to review and conduct analysis on staffing investments, looking at things like what's the footprint of staff by the types and program areas of the activities that they're doing, what's the staffing composition by cadre and distribution across geographies within a country, how does your staffing across PSNUs align to program targets and target achievement, and to identify areas where staffing might need to be better aligned to meet the needs of the program in COP21. That could be things like decrease or increase in footprint of different types of staff, or redistributing different cadres across PSNUs to better meet the need of program targets. The guidance also recommends examining and incorporating HRH staffing implications to further scale and maintain service delivery adaptations that may have been made in the last year because of COVID-19, considering how those types of changes might be incorporated longer term and what the staffing implications of those changes would be. So the takeaway message from this slide is just, this is a summary of what Pepfar field teams have been asked to focus on related to HRH staffing in COP21. And so these are the types of things that field teams will be looking at. And it underscores the importance of consistently collecting and using staffing data to inform how you're managing your staff and the types of staffing investments that you have as a program, and ensuring that the staff that you're investing in are right-sized for the service delivery needs or the other types of work that your program might be doing. I think we may take a pause now and see if anyone has any general questions for myself or for Diana. And
Carolyn,
then
we have 2 questions, I think, so far. If folks want to add other questions, I'll read them out for you. Does that work, Carolyn?
Yes, that sounds great.
Okay, great. So we have one question from Andrew Brown. With regard to the solution, the HRH needs an optimization planning solution, can you expand on what inputs are used in the tool to calculate workload and how this is contextualized to specific country contexts?
I can provide some more information about that, and then feel free to add in anything, Diana. The HRH needs an optimization solution estimates the total FTE of service delivery staff that are needed to meet targets for 3 different program areas, which are prep, testing, and treatment. And the way that it estimates that is based on a series of standardized client pathways for each of the Hrh indicators that are included in the analysis. What those client pathways are is basically an estimate of a standardized estimate of the types of health workers and the amount of their time that is needed to deliver different types of services to meet the targets for those different program areas. Those standardized time estimates are combined with the targets for each program area. And then there's an adjustment made for how much available working time the staff have to interact with clients. And that produces a total estimated FTE that is needed to meet the service delivery targets. As far as how it's customized and contextualized to specific country contexts, there are a series of, they're called customization parameter questions in the setup of the new analysis that are answered by the country team and help provide more context to how services are being delivered in that OU. And the responses to those questions are used to help tailor the analysis for a specific service delivery context in that operating unit. Do you have anything else you want to add on that, Diana?
No, Geraldine, I think you did a great overview of that. And for folks who are also interested in learning more about the HRH solution, we're happy to provide more details. There is also a briefer that is posted on the DataFi website, which is the partner that we were working with to build the Hrh solution. And I could post the link there in the chat for folks to look at. Geraldine, we had one more question about that solution. So it has a question around whether or not the dashboard takes into account any staff that are supported that are not supported by Pepfar. So specifically asking about it capturing MOH funded staff.
Yeah, that's a great question. At this point, the analysis only takes into account, the staffing data that is used as input for the analysis is only Pepfar supported staffing data. In part, this is because there's been lots of challenges historically with getting comprehensive MOH staff that are working alongside Pepfar staff in different facilities or community areas. So what the analysis does is it uses the input of the type and the number and the distribution of Pepfar funded service delivery staff, but then the total need that is estimated could be met by other sources outside of Pepfar supported staff. So for example, when in that one dashboard example where it showed current staffing compared to the total estimated staffing need, that doesn't necessarily mean that that gap has to be made up for by Pepfar supported staff, but it can be used to help kind of jog conversation about the other types of staff that Pepfar supported staff may be working alongside, like government staff or other donor staff, to help meet the total service delivery staffing that is needed to deliver all of those services. Hopefully that helps. Feel free to add anything else, Diana.
Great, thanks. Yeah, and I would say that the solution could be run with any available data. So it could be run with government data that were available, but it was built also to help really inform more strategic Pepfar investments. I think that is, hold on, we have a couple more questions. Let me see. I think that is all the questions that we've gotten so far. So with that, Geraldine, I think we can move forward.
Okay, great. So we can go to the next slide then. And I would like to extend a very warm welcome to Professor Sam Phiri from Partners in Hope in Malawi, who has kindly offered to share about the work that they have done with Hrh Data and how they have used that to inform their program in Malawi. Thank you, Sam. Please take it away.
Thanks, Sakya, Jerry, and thanks everyone. I would like to thank the organizers for allowing Partners in Hope to present its experiences when you're looking at Hrh in this case. So I think if you move to the next slide in this case. So we are talking about optimizing health workforce staffing through advanced data and analytics. So that is the implementation of the HIV program, at the same time looking at what is required as an investment for Hrh forward. Move forward. So just briefly for the Partners Hope, I think because of the timing, I didn't want to go through the Malawi profile, which I think most of the people on the call are familiar with. But just to mention that Partners in Hope is a local indigenous Christian non-governmental organization. And it has like the component of the medical facility, the medical center, which actually provides the medical services, including a molecular laboratory. And at the same time, it has a Pepfar funded program through USAID and is supporting 8 districts across the country. At the same time, within 101 health facilities. Move forward. So the Pepfar supported program through USAID is optimizing HIV services for epidemic control. And the primary goal of this program is to reduce HIV incidence and HIV-related morbidity and mortality. And it also to accelerate progress towards HIV epidemic control in Malawi through implementation of evidence-based and cost-effective innovative interventions to make sure that we increase the case finding, linkage, and also viral suppression amongst people living with HIV. It is a program which has been running from April 2019, and the program implementation in terms of activities running up to 30th June 2021, with a closeout up to 30th September 2021. Move forward. Next. So when we look at the objectives of the program, we're looking at the number and proportion of people living with HIV, which are identified using the efficient testing strategies, but also quality care and treatment services for people living with HIV with the health system component, and also strengthening of the site level quality management of the epidemic control, at the same time supporting the national viral load testing program for epidemic control. Next slide. So when we were in the financial year 20, we were implementing the program, and in the implementation of the program, there was a component of a site level HRH investment, but also above site HRH investment with components of technical assistance with mentoring. But from October 2020, which is the financial year 21, Partners in Hope transformed this staffing approach, therefore increasing the site level staffing to greatly expand direct service delivery. So a couple of components over there, as I mentioned, that there was a redistribution of site level staffing across the 8 districts, and in the 101 health facilities. And this was guided by a component of 1, treatment curve volume. So whether sites had less than 500 patients alive on treatment, or between 500 and 2,000 patients alive on treatment, and the others above 2,000 patients alive on treatment. The second was to look at service needs as assessed from the performance data dashboards, and also thirdly, the human resources for health optimization tool for IRT service delivery that was conducted in the country. We adjusted mentorship approach. So instead of doing the mentorship team structure, the mentorship frequency, and then we shifted the district level mentors to direct service delivery at the health facilities. And also streamlined management structures and shifting resources to the recruitment of additional site level service delivery staff in this case. Move forward, next slide. So using actually the guidance for COP20, as I mentioned, I looked at health facilities with a treatment curve less than 500, and then those with 500 to around 1999, and then above 2000. And also we're including the Partners in Hope Medical Facility, which operates as a center of excellence along with the molecular lab. So when we did these assessments, we realized about 23 sites with less than 500 out of the 101. And so the staffing there, according to the provision, we have HIV diagnostic assistants, an average of 2.5, patient supporters. So HIV diagnostic assistants are the ones who do the case identification, test 95. Then patient supporters, these were a replacement of expert clients. Previously, we're using expert clients where people living with HIV been on treatment for some time and they have a personal story to the program. But then these were, some of them were less than actually 2 years of secondary level. Therefore, Partners in Hope from October 2020 decided to engage more professional cadre of all-level component of education called patient supporters. And then we have the data clerks, and this case, patient supporters 2.5 average, and then the data clerk mentors 1.5 average. 60 sites with 500 and up to 1999, and the HIV diagnostic assistants, about 5 of them per site, patient supporters 5, and medical assistants about half as an average, with the data clerks 2 per site. 70 sites with the more than 2,000 patients, and the HIV diagnostic assistants being 8, patient supporters 9, and then you having clinical officers who are the equivalent of physician assistants certified in the US and then community HIV nurses and data clinical mentors with those averages. So the average on the medical site is stipulated at one medical facility, which is the Center of Excellence, which had the numbers of HIV diagnosis assistants 5, and then patient supporters 8, clinical officers 5, because they require more robust clinical care. Community HIV nurses about 9, with lab technicians and the lab data clerks and pharmacists to manage that. Next slide. Next slide. So we talked about the HRH optimization, which was done in the country to determine the optimal number and card of healthcare workers needed at the site, and then assessing the current site staffing in the terms of staffing gaps, and also the determination of provider and client ratios compared to treatment care, and providing dynamic tool for service delivery partner facilities and other stakeholders to configure their health workforce for HIV services, including actually MOH staff. So we'll present a few slides just with experiences and how we're able to utilize these within our programming. Next slide. So as part of the 2030 HRH, as I mentioned, we are talking about health optimization tool for ART service delivery, HOT. So this was to assess staffing levels and determine the optimal number and type of healthcare workers needed to accomplish the Malawi Pepfar COP20 PIH targets. And so the service provider and then cadres, as we can see over here, we're looking at the medical doctors, then physicians, clinical officers, and clinical technicians and medical assistants, and which are the majority. And then the nurses and midwives are more. These are the registered nurses and midwives. The community nurses, others are called linkage nurses, nurse midwife technicians, and nursing officers. The community health workers, these are the community health workers. And then the HIV testing providers are the HIV diagnostic assistants, the HIV testing counselors, and the HTS providers as called within the different partners. Then we have the expert clients, the peer educators. So when this was being done, the Partners in Hope had not transitioned from expert clients to patient supporters. But in the later programming of PIH, you'll be seeing more of the patient supporters. Next slide. So the human resources for health optimization, the tool was used in 18 PIH direct service delivery sites with the client cohorts of 2,000 and above. And actually these were divided into the 8 districts as actually shown on this slide. And in this case, there were several variables that were available. And in those variables, several variables were analyzed to determine staffing requirements, including information on ART treatment models and healthcare workers, clients, tasks, and task shifting practices. Data was collected through focus group discussions with the PAPs for selected ART providers, and there was a review of the HIV and AIDS guidelines of the Pepfar guidance. There were some telephone interviews with ART clinic in charges, some interview discussions, and PIH ART technical team validating the analysis in that component. And we move to the next slide. Next slide. So I think as a summary for this slide, the HOT for ART assessment showed that overall, in the 18 Partners in Hope sites, the requirement according to the provisions, we require 401 healthcare workers full-time equivalent. However, by the time of the study was being done, there were about 454, which was 113%. So this was an excess of 53 full-time equivalent, which was a 13% excess. So results actually differed across cadres, but the shortage of non-physician, clinicians, and community health workers, but there was an excess of expert clients, peer educators, and data clerks. And as I mentioned, this is what we saw, that we transitioned from the expert clients to the patient supporters, and we have tried to now modify and also make sure that we harmonize and make sure that we have available staff according to what is required within the sites. Otherwise, the dashboard which is available here, it is showing that the doctors and physicians, nurses, and community workers, you see that the expert clients and the data clerks were the ones who were in excess in this case, and the PIH was able to look at that as part of optimization. Next slide. So the limitations and challenges of this assessment was that accuracy of results of the analysis are highly dependent on the quality of the data inputs. It was difficult to access consistent staffing data, particularly for government staff, if you include them. But when you only use the partners of staff, you'll be able to have accuracy over that. Of course, the COVID-19 situation exacerbated the situation since the assessment team was not able to independently validate the staffing data for government workers, such as non-physician clinicians and nurses midwives at the site level. Move forward, next slide. So the major changes of HRH transition, the central clinical team, I just wanted to mention that previously before FY21, as I mentioned that we had a significant number of the clinical teams of the central clinical team, which was available at the central office. And then this was actually providing mentoring within the sites in the districts and the facilities. And also there was our teams within the districts who were also available at the district and then moving to the facilities. So the role of the clinical, the central clinical team was to cover grant needs for planning and the reporting to national TWG and donor representation, and also some of the components of looking at the design and startup of the new initiatives. So before they were providing direct clinical care, but now all clinical team staff's duties have changed so as to provide direct clinical care at supported facilities once every 2 weeks at a minimum. So these are the ones who are at the central level in Lilongwe. They're able to provide care, for example, at the medical center clinic, and also in some of the facilities within Lilongwe. And the clinical teams are systematically reviewing individual patients' level decisions for HIV viral load, high viral load patients beyond site level before. Currently, this team are responsible for reviewing and remediating patient-level clinical interventions for high viral patients. So it's just, instead of just saying, these are high, let's manage them, they are also looking at what are the strategies that we can do for high viral load management within the sites. Next slide. So we're looking at the role of the district teams in this case, and these were called the district mentorship team previously before FY21. And the idea was that they would report to the district health office and faith-based organizational coordination, and also clinical care and mentoring supervision. But now with the transitioning, these have changed to district clinical teams to reflect that these, when they go to the sites, they are there working in the nurse review and clinical review rooms, working with the teams there. As they are seeing the patients, they're also doing capacity building. And the district members, in this case, currently they are continuing full-time presence at the sites, and they emphasize on supporting direct care provision available there. And the coordinators, these have also changed as to provide direct clinical care and supported health facilities once every 2 weeks at a minimum to make sure that they're part of the direct service delivery. Then we have the district clinical teams who were previously responsible of only doing minimum amount of clinical care, but now 50% of their time is actually dedicated to direct service delivery in this component. Next slide. So in terms of the facility clinical teams, in summary, these are the expert clients. Now previously they were doing like 20 hours a week. They were receiving stipend. Now we have replaced full-time employed patient supporters, and the minimum roles include demand creation of services, linkage, back to care, and individualized patient support services that are provided to our patients. And the HIV diagnostic assistants, beyond actually the first 95, they're also responsible to include efficient case finding, third 95 activities, for example, the index case testing, EID, adherence, retention, viral load, and also management of advanced HIV disease. And this is like a support in terms of the testing to make sure that the clinical team are available. We have 8 psychosocial counselors who are placed in the district hospitals and mission hospitals, providing psychosocial support, disclosure, adherence, and also retention on high viral load. Then in the data clinical mentors, currently these ones are increasingly accurate in this case, doing the to make sure that they're looking at the EMR and also the eMastercard and point of care services for faster data informed programming decision making. So because some facilities do not have enough clinicians and nurses, we're able to hire about clinical officers and medical assistants to be available in the sites for the ART optimization, differentiated service delivery modules, and also opportunistic infections and the high viral load management. Next slide. So this is a busy slide, but I think this is the PIH staff final distribution per district following on our assessment, including the Hrh assessment. So now this is into the 8 districts. We have 2 scale-up districts, Lilongwe and Chikwawa, and these are the ones we have who have a lot more allocations. And then we have 6 sustained districts in the central and northern region and southern region too. And you can see that in terms of allocation to staff is proportional to the target, and the key parameter was treatment care in this case. So this is just to show, and whenever you get the slides, you'll be able to understand what is allocated. Next slide. And just to mention on the previous slide that that was the provision we thought we would need in the 101 facilities, and we completed recruitment in October 2020. So currently we are operating on full mode. Tracking and monitoring PIH health workforce, we actually have monthly data dashboard review, which in the health facilities, we have semi-annual appraisals, which we do. We usually do weekly virtual meetings, and in this case, and then we have data review and performance, which is used to relocate staff to various sites based on the performance. So the high performing sites, low performing sites, then we look at what are the issues. If it's related to HRH, we're able to reallocate. I'm just showing you some of the challenges that the district teams usually face. You can see one of the supervisors trying to cross the stream during the rainy season. So it can be really tough when we are actually working in the field. So we really appreciate and acknowledge the health facility staff as they're providing the services. Next slide. And I think as I'm going into the wrap up, I just wanted to quickly just look at the HRH changes which have been made and what contribution they have made to key performance indicators. And we are looking at the HIV diagnostic assistance in the FY21 first quarter. The HIV pause, as we looked at, you see that from when we moved into November. So after October, when we added more staff within the program of HIV diagnostic assistance, from November, we were able to move up above 100% target achievement, in this case for quarter 1 of FY21. And most of this was actually done beyond November, which was actually, but of course, as we know, when you move into December, there's a decline, especially when you also go into January. And COVID-19, a second wave for Malawi was actually apparent in the first weeks of January. Next slide. So when you look at the impact of the patient supporters, when you compare with the expert clients, we also saw that in terms of treatment new, this is actually after finding the HIV positives, the new ones, weight linkage. So that's escorting to the ART clinic. We see above 100% achievement of the treatment new when you look at FY21 quarter 1, as you can see in this slide. Next slide. And when we look at also progress on patient supporters on a retention back to care, follow-up patients after 28 days, we actually did generate 4,280 patients who were lost to follow-up missed points for 28 days from April to September 2020. But Malawi had suspended actually field visits because of the COVID-19. And then when there was a slowdown of that before the second wave, we were able to recruit to actually generate 4,000 patients and in that who were missed. And these were assigned to patient supporters. 94% were followed up. And then we had outcomes which have been reached over there in yellows. About 28% were brought to care. But you can see that others were live on treatment. and others also were silent transfers. They were looked upon as lost to follow-up, but actually they had picked up some medication, immediate supplies for other places, so they are really available on treatment. So you can add those to the back to care in this case. And then we have other outcomes like those who died, those who stopped, and others who have relocated to other places. 16% were the ones who were untraceable in this case. Next slide. And then we'll look at also the data collection commenters, the HIV diagnostic assistance, and the patient supporters' impact on the routine viral load uptake. We see that there was an increase from October to December of actually, when you look in this case, that the coverage was above 100%. They also uptake was about 120%. And also in this case, the suppression was about 94%. So this is an impact of actually uptake, coverage, and suppression when we look at impact of use of clean the data collects, HIV diagnostic assistance, and also the patient supporters. Next slide. As I said in the drawing up, the impact of training dedicated community HIV nurses who were deployed to the facilities. We actually bet all the targets from October to January. As you can see that we did HIV cervical cancer screening, and in this case, we were beating all the target in all the 4 months from October to January. This is because of the deployment of full-time community HIV nurses within the facilities. And in this case, we're able to do proper cervical cancer and optimized way of the program. Next slide. So COVID-19, we put in place by peer, we had put actually into place some COVID-19 actually to continue our services, and we made sure that our staff are protected. So Central District site level staff are being actively trained and updated in COVID-19 basics and infection prevention control. And we have PPE procurement and distribution to all the 101 facilities. And then the mental health support is available. The PPEs are available for Pepfar supported staff and also government supported staff. And then there's teleworking schedules to make sure that we decongest the facilities. And we do weekly virtual meetings and also including supervision virtual. As we are doing this meeting, actually, we have our teams doing a virtual supervision in one of the districts in the central region called Kasungu. And then we use our phone to support linkage, adherence, retention, and viral management. Regularly, we review the situation at the district and health facility levels at almost a daily basis. And then just to mention that we had also most of our staff, about 59 staff of PIH in all the facilities were actually infected and isolated, but all of them are now off isolation and they are back to work. And we continue to provide the services. And currently, we started, Malawi started the vaccinations on the 15th, and therefore of COVID-19, and our staff are being taking vaccinations in the facilities where they are staying. Next slide. Next slide. So in summary, we are saying tracking of Hrh data influenced deployment and redeployment of staff based on facility needs. There's a shift to more direct service delivery influenced more centered patient care at the facilities, and also transition of expert clients to patient supporters influenced the program performance during the surge in FY21 Q1. And there's a shift and availability of full-time data clerks at the facility, which improved the facility data management, data quality, and the reporting for program review. And also the training dedicated of healthcare workers like cervical cancer providers at sites. This actually has improved the program performance as shown in the presentation. And the last slide. So this is just to show how the teams work out when they go to the facilities. I'd like to thank the team, the clinical team led by Prof. Van Institute, the M&E team led by Mackenzie Shivara, and the rest of the program at the central level, district, and the site level. And also, I would like to thank the American people for supporting this program in Malawi. Thank you for listening. Over.
Thank you So much, Sam, for your really interesting presentation. I think we've gotten some really interesting questions that have come in. We're going to move forward into the next presentation, which is from Dr. Goodluck Mwakitosha with the Benjamin Mkapa Foundation in Tanzania. I'm keeping track of questions, and we'll have some time for more discussion and Q&A with the presenters at the end. So please continue to enter into the chat box, enter into the Q&A box any questions that you have, and we will discuss them at the end. Next slide. But we're very excited to have Dr. Goodluck Mwakitosha present about the above site work that the Benjamin Mkapa Foundation does. And I will hand it over to you. Thank you.
Thank you very much. I'm Goodluck Mwakitosha, and I'm working with the Benjamin Mkapa Foundation, which is a local partner in Tanzania, which has more than 14 years experience, mostly working with the Hrh management, as well as transitioning into government for continuity of service delivery. Next. Yeah, I will briefly talk about just a little bit of introduction to USAID Afya Endelevu activity, as well as highlighting on the interventions we are doing to address the bottlenecks in Hrh management, but also experience based on Benjamin Mkapa Foundation on how we are building on that experience, as well as what we see after 1 year of implementation of this activity and the way forward. Next, please. USAID Afya Endelevu is a 5 years award to Mkapa Foundation, which is mainly focusing on supporting allocation and deployment of appropriate type and number of qualified healthcare workers to support the acceleration of HIV, TB, as well as maternal and child health services. And it is covering over 490 health facilities located in different, more than 90 local government local government authorities. And it is almost reaching more than half of the regions in the country. And this activity has been implemented. For now, it's 1 year. Next, please. And the main focus of it is to also strengthen the alignment of Pepfar supported healthcare workers with government policies and practices, but also aiming at sustainability and also supporting the leadership of the government in terms of human resource management as well as the planning. So I will also talking about what USAID Afya Endelevu is doing to address the bottlenecks in human resource management. And the one key area is the issue of standardization, aligning service delivery targets with the allocation of human resource. And this has been, we've been doing it through the aligning with the service delivery targets, working with the service delivery partners, because this activity is supporting is mainly collaborating with the service delivery partners to ensure delivery of quality health services. So we have been working through the government to ensure that the recruitment is aligned with the policies as well as practices. Also standardizing the benefit package with the government in order to pave the way for sustainability. In order to address the issue of stewardship within the government, the activity is also working with the government to ensure that we maximize Hrh impact by ensuring that we do a lot of advocacy as well as the management to ensure that some of the cadres which are not recognized in the government, such as data management, data clerks, as well as community health workers, are recognized in the government structures. they are supported and they are included in the establishment. Next, please. Benjamin Mkapa Foundation, as said, has been working in Tanzania for more than 14 years. And it has an experience in human resource management, as well as capacity building. In the past, it has been working with the government, as well as the service delivery partners, to ensure allocation as well as distribution of healthcare workers, to ensure acceleration of service deliveries, particularly in HIV, maternal, as well as TB services. In the past, it is from the allocation of the healthcare workers who were more than 300, 500, were allocated in more than 130 local government authorities. It had proven some impacts, especially on the enrollment of HIV clients, more than 5-fold in the past 5 years, but also delivery, health facility deliveries, maternal deliveries, increase of more than 20%, which was in 2017. But also the PMTCT coverage were increased from almost 30% in 2017 through this. And also, we have been working with the government, it has been working with the government to ensure alignment of these recruited health workers, and more than 80% of the recruited health workers were successfully absorbed within the government system and continued providing services in the same geographical areas. Therefore, USAID Afya Endelevu is leveraging on these experiences to ensure that the allocation as well as the identification of healthcare workers is based on this experience, but also moving forward to ensure that we also improve the government human resource leadership as well as planning. Next, please. The activity has been implemented for 1 year, since February last year. And so we have some issues which we have been seeing for us, we see some of the improvement. And one is areas which have been working is about alignment of the recruitment with the government policies as well as practices. And one of the area in this is the standardization of a salary scale for the healthcare workers, because in the past, most of these HIV-supported healthcare workers were being managed through different service delivery partners, and they have different package of salary payment. So the activity has played the role of standardizing the salaries of 921 HIV-supported care workers. And out of those who are standardized, because some of them had higher salary, very few had lower, we also experienced some dropouts, which were not that much, and did not cause much of interruption to service delivery. And in the recruitment process, we usually engage with the ministerial entities responsible for recruitment, where all posts and the new posts are selected based from the government job application database, which have verified applicants of various skills, of which we found this as an indication for absorption of these healthcare workers within government system when employment permits are released. And currently, 920 healthcare workers are full aligned with the government salaries. This is out of more than 1,000 healthcare workers whom we are managing. We have also seen more data use within the activity, aligning more data with service delivery targets as well as priorities and performance. And this has been also doing in consultation with Touch Foundation. You are applying POA. And also we believe that currently the management of healthcare workers are more coordinated. It's easier to find the inventory from one place, knowing where the healthcare workers are, compared to the past where the healthcare workers were distributed in different and managed by different entities and different service delivery partners. We have also find that there has increased the availability as well as visibility of healthcare worker support where we entered the human resource into the government human resource information system, whereby it's easier to find the support, the project support or the activity support in comparison with the government healthcare workers available in those health facilities. Following the standardization of package, we also see cost saving, which is an opportunity for adding more healthcare workers. And we just computed for 1 month before standardization and after standardization, finding out that we can add middle cadre healthcare workers of about 100 whom can go beyond the coverage, but also go into more geographical area. But also this is, we have seen also offloading the technical assistant partners from human resource management, which has a lot of components to deal with. Next, please. There are some few areas which we see as a challenge, particularly because there's a variation in terms of service delivery, priorities, as well as targets. And sometimes we find out that the demand for healthcare workers is higher compared to available resources or allocated budgets. And sometimes this becomes routine requests from service delivery partners, but also from health facilities which we are supporting. But also during aligning salaries or benefits to healthcare workers, we found that some are dropping out with their experience and bringing in new healthcare worker. We found it sometimes needs more training because the one who left had already been given experience. But also in the issue of COVID-19, we have been seeing some kind of reported commitment, less commitment, especially in patient care, but also in terms of testing. But this, we have not going too much to qualify this because some of the reports is that clients are not going to the facilities, especially during the high peak of COVID. So it might be one of the cause, but also staff have, most of the healthcare workers has inadequate supplies of PPEs, which are sometimes limiting them from providing services. They do get PPEs from the government, however, they are not enough, and sometimes they do have to request from other sources. And also there was a reported workload due to added screening tasks for COVID in some of the facilities. So some of the healthcare workers were given a task of screening or being shifted to isolation centers or assigned the other roles due to COVID-19 outbreak. Also, there is a need for more capacity building to healthcare workers, especially for the newly recruited, of which the demand is being leveraged by the other, by the facilities and the other healthcare workers. Next, please. So going forward, we plan for more data use to improve the continued data, improving data use by engaging with the Touch Foundation and also having a standardized tool for identification as well as the allocation of healthcare workers, as it was presented in the beginning here. Also focusing more on performance and productivity of healthcare workers to accelerate service delivery. And this one, we already have the USAID toolkit, which has been customized, and also having some improvement package for the healthcare workers' performance. but also continue with the engagement with the government as well as the faith-based organizations and institutions to ensure the sustainability of the HRH investment in the health facility, within the health facilities or within the government, because those of the FBO, we also expected to leverage the Touch Foundation experience on business model within FBOs to ensure that the healthcare workers who are located in FBOs are sustained within the FBOs. But also, lastly, to continue collaborating with the service delivery partners in terms of alignment of service delivery targets, performance, as well as the allocation and distribution of healthcare workers to improve the service delivery. Next. Thank you for listening, and we really thank USAID and Pepfar and the USAID team in Tanzania for the continued support they are providing to us technically, but also an oversight. Thank you very much. Over to you.
Great. Thank you so much for sharing about your work. And now we can move to the next slide. And we have some time now at the end for discussion and questions and answers. So I have some questions that have come in for the presenters during your presentations that I'll pose to the presenters and they can respond. If you're listening, please feel free to add in other questions that you'd like to see responded to into the Q&A section, and we'll address as much as we can before we close. And anything we're not able to get to today, we can respond to in writing after the call. So the first question, and I see that the poll has popped up as well, so please respond to those questions to provide feedback on the webinar today as you have time. So one of the first questions, which was for Sam with Partners in Hope, was someone asked about what the role of a key populations navigator is and how it differs from a peer educator. So the difference between a peer navigator and peer educator in your model. Sam, would you be able to answer that?
Thanks, Jerry. I actually typed the answer in the chat, but just to confirm that was coming from the national evaluation of HRH. So in that case, this actually was when the Hrh for Art was done. It was done across all the partners who are implementing HIV program in the country. Partners in Hope is a care and treatment, but because it was for all, sometimes it is the way partners are labeling the either peer educator or peer navigator in that case. But one of the things which I mentioned, for example, within the Partners in Hope, we do not have that cadre. So in that case, it is within the key populations programming. But from what we know as they're operating, the educators, they are there, and some of them, they are providing the demand creation and also some of the key service delivery like components that people should know in terms of what services people can get in the facility or where, either facility or community. So the navigators actually usually these ones, when they identify, they are like the running team, and usually what they do is they, amongst their peers, they would, once they identify that someone is positive, for example, they would say, okay, come here for HIV testing. When they're positive, they will take them as a weight linkage into the ART treatment. If it's a female requiring cervical cancer screening, they would escort and go there. If it's someone requiring sexual and reproductive health services, including family planning and STI treatment, they will take them over there. So these are the ones who I can take them around to make sure that they are not lost at the facility, because otherwise, if they don't have that component, they may be able to not actually, they will be able to go out and think that they're not welcome at the facilities. So this is what I would say between those two roles in that case. Over.
Sam. Dr. Mwakitosha, I have a question for you in general about your presentation and the work that your organization has done. Could you, so we've talked a lot today about the types of data that it's helpful to collect on health workers and ways to use that data to inform programming. I'm curious if you could speak a little bit more from the work that your foundation has done with a number of different organizations to increase their capacity to have and use data on health workers. If someone were just getting started with setting up a system for tracking their health workers, what types of information would you suggest that they focus on collecting first? And do you have suggestions or guidance for partners that might be new to collecting this type of information?
Thank you for that question. And from the previous Mkapa Foundation implementation, the most used approach was to engage with the local government authorities as well as the specific health facilities to identify the workload, but also using the performance indicators within the which are available in the national HMIS regarding the specific health facilities, also comparing the existing government staff who are directly providing the specific thematic area which we intend to support. So using that information first, it informs on the requirement in that health facilities, but also understanding on the specific local government authority planning, because they have a personal enrollment planning for sometimes for 1 year or 2 years, and also 5 years, to understand wherever they have a permit, how many staff are they going to receive, to avoid taking staff to one facility and then at the same time the government also allocates staff at that facility, which will cause redistribution and the additional cost for redistribution. So that is the main approach of aligning with the existing data from the government source, but also from the health facility themselves. Over to you.
Thank you. And others, please feel free to continue adding in questions and we can get to them as we move forward. I thought there was one question that was directed at Sam that you'd responded to in the chat, but I thought it was really interesting and might be useful for others to hear what your response was. So one of the attendees asked, during the COVID pandemic, what strategies did you use to make sure that people living with HIV who are on antiretroviral therapy don't have interruptions in their treatment, since community expert clients were not allowed to do home visits during lockdown? Sam, could you review for the group what Partners in Hope did to help mitigate the impact of this on clients?
Okay, thanks, Jackie Jerin. So in this case, it's true that the expert clients were not able to go out to the field. So first, we were actually making sure that we are optimizing on use of reminders on the phone. So for the ones who actually have phone access, then they were getting reminders on when they are supposed to come, and also to let them know that although we have this, we are basically providing the services to the people living with HIV who require to pick up their medication. And then we will, if they missed an appointment, then we would also do a call to make sure that we let them know to come. When they come to the facility, or when everyone was coming to the facility, we actually optimize the mathematical prescription. So we relaxed the eligibility for a 6-month supply was actually extended in this case to everyone unless they were sick, rather than to stable patients only. So as long as you bumped into the facility, then you were given a 6-month supply, and to make sure that we see during the COVID component. Then we're also emphasizing on the patient education in the waiting area to make sure that we are continuing to provide the service, and then word of mouth, guys can actually communicate to their colleagues that we are providing the service. They should come and collect and continue to make sure that they continue their medication, because if they don't, then their viral load might start to rebound. So that's what I would mention for now. Over.
Thank you, Sam. There were two questions related to standardization or kind of salaries in Tanzania and transition of Pepfar supported staff into the government of Tanzania healthcare system. So I'll summarize those two for you, Dr. Mwakitosha, and if you could respond to them both, that would be great. The first was, during standardization of salaries in Tanzania, did you have to reduce some workers' salaries? Did that affect, did you make those salary changes all at once, or was it staggered? And then the second question was, if you could talk a little bit about how easy or difficult it was to get Pepfar supported staff absorbed into the government of Tanzania healthcare system, and what has happened with the remainder that have not been absorbed into the system.
Okay, thank you. I think you will repeat the second question. Let me go with this first about standardization of salaries.
Sure, no problem.
Yes, if we reduce some workers' salary, it is most of the healthcare workers, they had different salaries based on which partner they were being supported by, service delivery partner, but and some had lower, not all of them who had higher. So before going into that standardization, there were some steps towards informing the health facilities management, medical officers of the health facilities, but also the staff themselves, the healthcare workers themselves, as well as the local government authorities. There's a discussion, and then healthcare workers were given opportunity to opt for continuing under the standardized salary, with the explanation on the benefits for standardization, because one of the benefits which was explained is the possibility of being absorbed in the government system, be employed by the government if the employment permit becomes available. Because when they are standardized, it will be easier for the government to take them into employment, because they know they will stay and they will be retained. So this was that. And then, as we saw, about 20% of the healthcare workers declined the offer. And from there, we continued taking new staff with the new standardized salary, which was not a problem. So majority accepted and continued with the service provision. Over to you for the second question, please.
Sure, and the second question was, how difficult or easy was it to get the Pepfar supported staff absorbed into the GOT healthcare system? And where did the remainder who were not absorbed go?
Okay, for now, within this activity, we have not have healthcare workers who have been absorbed into the government within this 1 year, since the government has not given the employment permit for this past 1 year. But for the previous projects, the absorption was easier because of the alignment with the government policy and practices, including the standardization we're talking about. And most of this employment is done in collaboration with the government employment entities, the ministry which are responsible for employment. So this staff are within, we make sure that they are within the government application database. So wherever the permit comes, the priority becomes for those. Though there is a challenge of the permit, because sometimes the skills required and the focus of the permits does not align with that. So that's why you find not all of the healthcare workers will be absorbed. However, those who are not absorbed, for the previous projects, they continue being with the project up to if there is another opportunity for permit. And then some of them were experienced health facility themselves using their own source they've been able to continue in supporting those healthcare workers within the facility until waiting for the permits to be released, for the employment permit to be released. Over to you.
So much, Dr. Makitosha. Okay, I think that's about the end of the questions for the two presenters that we just had. I'd like to actually ask a few questions of the people that are on the line, of the participants. I'll put those questions into the chat box, and I would love to see some responses in the chat if possible. The first question is, what type of staffing information do you currently collect through your program, and how do you use this data right now? The second question is, what impact has the COVID-19 pandemic had on the health workers that you support? And the third question is, are there changes you have made to your staffing and service delivery models as a result of the COVID-19 pandemic that you plan to continue longer term? So I've just entered those three questions into the chat box, and I think it would be interesting to, if you're able to share some insights from your program settings, it would be helpful to hear from you all about your thoughts on some of these questions. So how are you using staffing data right now? And more information on how the pandemic has impacted the health workers that you support, and more about changes that you may have made to service delivery during the pandemic in the last year that you might be seeing benefits of and decide that you want to continue longer term in some form. So we can give a few minutes for people to respond in the chat. And if you have other questions, please feel free to put them into the Q&A. And if there's anything that we're not able to get to today, we'll respond in writing afterwards and send out materials after the call. So we'll give a few minutes now for people to respond to some of these questions. Maybe while we wait, either Professor Sam or Dr. Makitosha, if either of you have thoughts about these questions from your own experience, you're welcome to come off mute and share your reflections. That would be helpful. Thanks everyone for your responses so far. I'm seeing some interesting notes from Katie that at certain intervals, some staff have had to do more work due to other staff who are isolating or in quarantine. Another has implemented a wellness program to support staff with the challenges they've faced during the pandemic, like stress and financial challenges, and have implemented special leave so that staff who've become infected with COVID would not have to take sick, annual, or unpaid leave to cover that time off. Other changes have been made to the program to limit exposure. Teams were made to work weekly shifts and then the other week to work from home. Providing mental health support to staff, rotating staff. Great, thank you everyone. These are really interesting reflections so far.
So Jerin, I think on the component of what impact has the COVID-19 pandemic had on the health workers you support, one of the things which I think I wanted to highlight is that because we're supporting, in this case, especially the clinicians and nurses who supported under the program, these are basically most of them was HIV specialists or considered as HIV specialists. In this case, that they have a lot of experience on viral management. So in this case, the people who have been asked, for example, from a lot of people, either colleagues and things, to ask more about what the COVID-19 is and how does it cause disease. And also when they are having symptoms, they would also come forward and say, what do I do in this? Because the national program says I should stay home, but I want to go to the hospital. So some of those is coming in. At the same time, while people are depending on them to provide this, you see that there's a component where these are actually also getting infected themselves. Some of the staff were infected, some of them they had contacts. So it was actually difficult, and they were having some problems to cope. So that's why, for example, PIH had also a component of mental health support program that was able to support staff so that they should be able to call out and say what they're feeling, and they need to support them in this component. So I think those are some of the issues which I've mentioned over Jerin.
Thank you, Sam. And you highlight a really important issue, which is that we've seen a lot of evidence that the additional stress of providing services during the pandemic definitely has impact on mental health and wellness of health workers. And so there have been a lot of recommendations of the need to provide mental health and wellness support for staff to support them to be able to continue doing their jobs in extremely difficult situations. And I'm seeing a number of people commenting on using different things like supportive audio messages for health workers to help minimize mental stress, introducing wellness programs, mental health programs, and expanding different types of service delivery models, like using virtual mentorship and supervision models to service delivery sites. And one comment that they plan to continue that approach of using virtual supervision and mentorship for service delivery to continue that post-COVID. And yeah, thank you everyone for sharing your reflections. This is really helpful information to see. Okay, well, I think if you have any last questions, please feel free to continue putting them into the Q&A. We have just a few more minutes, and then I think we will probably end a little bit early. And if there were any questions we were not able to get to, we will respond afterwards as we send out the webinar materials. Okay. Thank you, Dr. Makitosha. That's really interesting. You said you have a social network group for communicating with healthcare workers in different regions and zones. I'm curious, Dr. Makitosha, could you talk a little bit about how, so you've used that to communicate information with healthcare workers. Has that been primarily a way of communicating updates and information to the health workers, or has it been sort of two-way communication to get information back from health workers on the context for service delivery in different areas, like whether there's enough PPE, how service delivery is going, things like that?
Okay, thanks. The groups are formed by our zonal or regional field officers, putting all of the supported health workers within that network. And they do communicate not only the issues about COVID, but any other issues or challenges they face in terms of implementation. And our teams usually communicate or sometimes escalate the issues to other level based on the issue itself. And also that one is also used to share key information, especially on the awareness as well as the educational materials to the staff. So it is a two-way communication part of platform. Thanks.
Great, thank you so much for the update. Okay, well, I think that will wrap up the question and answer section for now. Hrh or Catherine, do you have anything else in closing?
No, thank you so much, USAID and our partners for presenting and sharing your stories. We're really happy that we had the opportunity to focus on HRH. We have an active webinar series, and if you are interested in additional topics, your name is already included in the listserv, and you will be invited to all future webinars. Again, thank you, Diane and Geraldine and the 2 local partners. We really appreciate your time. And again, all of the proceedings from this webinar will be on our ASAP website. We store the presentations. Once the questions are answered, they will also be in the on our website. So thank you again, everybody, and thank you, team, for pulling all of this together. I hope everybody has a wonderful rest of your day. Thank you, and bye-bye.
Thank you, everyone. Have a good rest of your day.